So to start off with, I'd like to introduce Jean Robinson. Jean's a paediatric dermatology nurse specialist who works in London. She's got a specific interest in eczema, but she said she can discuss any of the other paediatric dermatology things you've got going. And her talk is called Connect the Dots, which I think is a great title for a paediatric dermatology conference.
Right, thank you very much. Okay, so I work in East London. Maybe if I just sort of let you know where I am and where I'm coming from. I work in a busy hospital over there. We have lots of inpatients, we have lots of outpatients, and I do quite often go down to casualty, which is how I met Tessa, who asked me if I'd like to come along today. My background is as a children's nurse. I've ended up doing children's dermatology, but I started off doing children's nursing for quite a while, and carried on very happily in hospitals for a while. Saw a little bit of eczema, but I don't remember much about it. And then in 1991, I went to work on the community children's nursing team in the area, and suddenly I had to start learning about eczema. I was meeting lots and lots of children like this. This is T-Rex, the Ichthyosaurus, and he's very cross. He's scratching, he's horrible, he's very upset. And I was meeting lots of children like this, and their parents were very upset. Their parents didn't know what to do. Their parents were muddled by complicated regimes. They had no idea how to put treatments on. But fortunately, Dr. Bill arrived for Ichthyosaurus, and I don't know that I'm small and squishy, but anyway. The other thing is that Dr. Bill actually knew what to do, and I didn't. So I've had to learn an awful lot over the ensuing years, really, about how to help families. And really, that's what I'm hoping to talk about today, so that some of the practical stuff, some of the less glamorous stuff we perhaps go through, so that hopefully everybody can be helping children with eczema a bit more. Okay, when I asked Tessa what she felt I should cover, one of the things was the issue about bathing, which has hit the dermatology world quite a lot in the last year. There's been a lot of controversy, really, in the last 10 years or so here in the UK about whether we should be using bath emollients to bath children. And there has certainly been a lot of talk about how much money we pour down the drain in this country. There was a study which came out last year called Bathe. It was conducted on children aged 1 to 11 years. They were recruited through GP practices, and most of them had moderate eczema. Almost nobody bathed more than 5 days a week, and actually a lot of them did admit to doing a bit of chucking some bath oil in occasionally. So dermatology really is thinking about this quite hard. We still feel that there is a place for bath oils. There certainly might be a place for antiseptic bath oils for children who are infected quite a lot, and certainly under ones. Mostly families do bath their children every day, bath their babies. So we still think that there may well be a place for that, and in children with more severe eczema, there may well be a place for that. We may be battling a bit against the tide, but the British Association of Dermatologists is having a good think about this. The National Eczema Society also is, and they were also rather concerned as well, because there are certainly quite a lot of cutbacks at the moment with some of the NHS advice on how to manage dry skin in children as well. Topical steroids. This was one of the other things that Tessa said would be really helpful if I covered. When I started, I had absolutely no idea what was what. Here in the UK, we have 4 strengths of steroid. I don't know if it's the same in Australia. Do we? Do we know? Don't know. The US, it's 7, so they're ever keen to make things more complicated. These are the ones that we tend to use. Most units will be using the same ones. I think generally now we're seeing far fewer branded steroids because they're more expensive, and most places are going for generics. So it's actually really important that you learn what your generic names are. And the things that I would definitely draw your attention to is the moderate one, clobetasol butyrate, and our super potent one, clobetasol propionate. And unfortunately, there have been quite a lot of incidences in the last couple of years where those have been muddled. And children have ended up having super potent steroid on their face and their moderately potent one on their body, partly because there was a problem with steroid production in one of the factories, and Umivate was not available, so a lot of pharmacies were dishing out the wrong thing. So you really are going to have to learn your generic names. What else about steroids? Things like Fucibet, which is a mix of antibiotic and steroid, we are using much, much less of than when I started sort of 20 years ago, and that's really because it's a mix. We will already have problems with resistance, antibiotic resistance, and the other major point is that Fucibet is a cream. What's safe to use? Well, generally, we will go up to moderate on children's faces. You need to be careful with faces and necks and eyelids particularly, but sometimes there is a case for using a stronger steroid in a child's eyelid, like a moderately potent one, if they've got very thickened eczema. You need to be careful of genital areas, and you also need to be careful about what you're sticking in armpits and groins. We do have some quite young children that need to have fairly potent steroids because they've got pretty awful eczema, but that's because we're dealing with children who are not primary care ones. These children have bad eczema. These are some of the packaging which will no doubt change and do often change. I've put this in to remind me just to sort of think about whether we're using cream versions or ointment versions. Most steroids do come as either or. Dermatologists much prefer ointments, and there is quite a difference. If you use a cream, it's water-based, it's actually got quite a lot more additives in it, so it is probably not going to be so useful. Some families will prefer it, but generally most families who've had an ointment-based moisturiser would prefer their ointments. So when you come to your prescribing, if you just write 1% hydrocortisone, pharmacy will make that decision for you, and it probably is a good idea to try and take that into your own hands and write ointment. How much should you put on? Well, back in 1991, somebody started thinking about a measurement and came up with fingertip units. I don't know if anyone actually uses these, but I've never understood how that works. A fingertip unit of steroid would be steroid from the top joint of your finger to the end, and that should be covering about 2 palms, adult palms worth of eczema. But my problem is, and I think most parents' problem is, that their children don't have nice handy bits, palm-sized bits of eczema sitting on them. So that's really quite difficult. We already make things quite difficult for these families because we don't give them just one thing to do. So I think it's really important that we try and find them a way that's a little bit easier. And what we generally suggest to families is they put a bit on their finger and they actually apply the steroid to the affected bits, which we'll do a photo of in a minute, and use that rather than fingertip units. One of the other things which we often find is that families have been told that they should only use their steroid for 5 to 7 days. And the problem with that is that most of the children we see with eczema have eczema that is definitely not going to clear in 5 to 7 days. So families will use it, things will get better, but they won't actually completely clear their eczema. So with the exception of when we're using a stronger steroid, on some children, we would generally suggest to families that they should really just put the steroid on until the child's eczema is no longer active, so until the lesions are soft and flat. And we do quite often actually get families to learn to feel their children's skin a bit more and go through that with them in clinic. I think what's really important when you get children coming to casualty, if you had a child with asthma coming, I feel pretty sure that you'd be saying to them, saying to parents, how many times have you used your child's inhaler today? How many puffs have they used? Are you using your volumatic? And yet, I get constantly called saying, could you come and see this child with eczema? Mum's using all the creams. We're not really asking enough detailed questions, and you need to do that with eczema. And we do ask families this when they come to clinic, and I'm certainly asking them if I'm seeing children in casualty, and it'd be great if they brought their stuff with them so we could actually check that out. Because generally, families are underusing steroids. I guess the other big message is that most families are worried about using steroids. They're worried about thinning the child's skin, and I think most health professionals are worried about using steroids as well. So unfortunately, we're all very good at passing on our worries to parents, and they pick up on that and actually continue to underuse the steroids. So actually looking to see how much families have used is really important. We frequently get families who come, maybe bring a tube, and they say, I'm using this all the time, and then we discover that they've used about 30 grams of steroid on their 8-year-old who's pretty much covered with eczema in the last 3 months, which is clearly why the child's eczema isn't better, and we then might be thinking about should we use something a bit stronger, but actually we haven't got the message across about how to use it properly. This is something that we typically get, and we see lots of children like this. This child is very dry. He's got loads and loads of excoriated areas. Often people are very unsure about whether to treat open areas like that. The answer is you should do. That's eczema, and that's why it's open. So you would want to treat those open areas. You do want to treat all the red bits, so there's quite a lot to do. I don't know whether you think that child's going to be very willing to have anything put on. Probably not, and I bet the family have been struggling as well, which really means that we all have to do a bit more about getting stuck in and actually doing it. Parents need to be shown, and then they will actually get the hang of it. The child's eczema might even get better as well, and that reinforces for them that that really was the right thing to do, and they feel better about doing it. That child doesn't have thin skin anywhere. This is all very thickened. So we definitely do want to be using steroid. We'd want probably to use something fairly potent on that, so mometasone or betnovate would probably be very suitable, but there is a lot of eczema to treat. So generally, if I'm seeing people with their children in casualty, we would, if at all possible, try and send the family round to pharmacy, get the stuff, and actually show them before they go home, because then they might have a chance of doing it and they might feel more confident, because they'll go home and the child will go, ooh, I don't want that on, don't touch me, don't touch me. Okay, so steroids, let's burn it. The other thing is moisturizers. I debated long and hard about whether to talk about moisturizers first or steroids first, and I've put steroids in first because generally I think children that are rocking up to casualty are there because their parents are really struggling and they're going to need some steroid. And if you are going to make a decision about which to do first, we would generally recommend you do steroid and then do your moisturizer. There was a study done about 2 years ago which didn't come up with any firm conclusion about whether it was better to do steroid first or moisturizer first, but I think generally it makes a bit more sense. The steroids are going to be soaking in a bit better, hopefully, and then you're going to put your possibly greasy moisturizer on. If you do it the other way around, you may be having quite a big, thick layer of occlusion, which is then more difficult for the steroid to get through. There's a huge mix, and I'm sure Australia has different things. So we have lotions, creams, gels, and ointments. These vary hugely, and we're getting more and more generics as well. So things like Epiderm, which is a good brand, we're seeing less of, and we will need to come up with something else. As a general rule of thumb, parents sometimes have an idea about what's good and what they would like to use. We try and encourage families to use the greasiest moisturizer that they will do, so that both they and the child will use it. If that doesn't work, then we have to think of something else. So if we give something very greasy to children and they haven't used it and they're coming back looking very dry the following time, then maybe we all have to go back and have a rethink about which one to use. The NICE guidelines, which were a national guideline that were published in 2007 in managing eczema, did suggest that children should have at least 250 grams of moisturizer a week. So that's half a big 500-gram pot, and most emollients are produced in 500-gram pots. So GPs might need to think about increasing the amount that they actually prescribe. Families are struggling to make their supplies last, and it doesn't always work. If the child's at school and needs to have an application at school as well, they're going to need a bit more moisturizer. So it's having a think about that. Some of these are a little bit older and the packaging has changed, but there's a huge amount on the market. So we do get families who say they've tried everything, but I don't reckon they have. Hopefully the message about olive oil has got through. There was a good study in 2012 which showed that actually has a bad effect on the integrity of the stratum corneum. So when you've already got a problem with your stratum corneum, you don't want to make that worse, so better not to use that. There was a study also which was looking at whether high-risk babies, so these are babies who've got a sibling with eczema or a parent who's atopic, if you use a moisturizer, one of these ones, from the word go when the baby is born, it does seem to have quite a good chance of reducing the chance of them developing eczema. So I think that's something that's worth hanging on to. And while I remember, I forgot to mention water softeners. A study in 2011 didn't show that water softeners were any help. Okay, so my friend again, he's still looking very bad. He's in casualties, waiting for a cubicle, or you might be thinking about sending him home, I don't know. But you know, the best thing to do is actually to help those parents and that child by getting the moisturiser on. And if you're on the wards, these children, one has been admitted, you know, have a look in your pot, see how much has gone. Generally, that child won't be wanting to move his arm. It's very sore, the skin is very tight, and actually getting some moisturiser on, which you might need to do, will actually be more use to that family than quite a lot of other things. If they are having lots of infections and you are using an ointment where you're having to put your hand in the pot and then back again, so double dipping and transferring any infection which he's clearly got into your pot, you might want to think about using either a spatula if it's an inpatient, or getting families to use a clean spoon and just take what they need out, stick it on a saucer and then use that. Sometimes with families, if they've got lots on, it's just they're just going to have to get on and do it, and then we'll worry about the other bits later. But that child absolutely needs some moisturiser. And if you are going to send anybody like that home from casualty, it'd be great if you did some moisturising before you sent them home, and also reminded families that they probably, like their EpiPen and their inhaler, it'd be a good idea if they took their moisturiser round with them as well. So if their child starts to scratch, they've actually got something they can do about it. So Itchy Saurus here is just about to have a nice bath. So Bill has done a good bath. And what's important, I think, about this is Bill's really recognised that it's very important that we teach people. So teaching by doing, and actually talking in words that they'll understand, is really important. Don't know where Itchy's parents are, but anyway, there we go. This jolly looking lot are actually really helpful. These are our health advocates, and we actually couldn't manage without them. We have a lot of families whose first language isn't English, and this lot are really helpful, great help to us. This lot, who are more jolly, are actually very helpful as well. This is the Community Children's Nursing Team in Tower Hamlets. We're very lucky that they're there. We do use other community children's nursing teams as well. This lot will generally go, if we make a referral, they will visit a family at least 3 times, so that, probably in fairly short space of time. They will go through treatments again, because very often in hospital we've gone through a lot. Parents mightn't have taken it all in, don't remember everything. A lot of families need reiteration, particularly about using steroids. They will go. They've got some language, Bengali speakers for our Bangladeshi patients, which we have a lot, so that's really helpful. And they will also help liaise with school, health visitors, and also the GP, so that we hopefully get families managing and getting enough prescribed so they don't run out of stuff. Okay, really, really important. I think Bill's doing a great job, and the good thing that is that he's actually doing something. So doing something will be really helpful. And thank you very much to Ross and to Grace, who helped me with tidying up my slides, and also to David Page and Adele O'Toole, who are the dermatologists who've taught me such a lot over the years and have been willing to work with me and other nurses and help families. So thank you very much.